Bismillahirrahmanirrahim. So now let's start with the cardiovascular system of the pediatrics. So firstly, we are going to talk about benign versus pathological murmurs. Benign versus pathological murmurs. For the benign ones, history. There will be normal appetite, energy, activities, and growth. No significant family history. Murmur features early or mid systolic. Grade 1 or 2 intensity that decreases on standing and Valsalva maneuver. Low pitched, musical, pure or squeaky tone, and left lower sternal border murmur, that is called as Still's murmur, or high pitched at left upper sternal border, which is pulmonary flow murmur. Okay, other findings are not present and workup is not indicated. If we have Still's murmur, which is left lower sternal border murmur, and high pitched murmur at the left upper sternal border is the pulmonary flow murmur. Pathological murmurs. The history is there will be diaphoresis and fatigue with feeding or exercise, poor weight gain, chest pain, dizziness, syncope, shortness of breath, family history of sudden cardiac death and heart diseases. Murmur features will be harsh, hollow systolic, diastolic murmur, grade 3 intensity or higher. Like the benign murmurs are grade 1 or 2 in intensity, while the pathological murmurs are grade 3 in intensity or maybe higher. Increase with standing and Valsalva maneuver. Other findings include loud fixed split or single S2. The fixed splitting is seen in the ASD. Decrease or absent femoral pulses are seen in the coarctation of aorta. Workup will show ECG to assess for the hypertrophy, echocardiogram to assess for the structural abnormalities, and cardiology referral. Then ECG findings in the hypertrophic cardiomyopathy. Left ventricular hypertrophy, tall R wave in the AVL and deep S wave in the V3, which is the Comel criteria. Okay, so what? There will be tall R waves, as you can see here, the R waves, PQR, ST. So these R waves are like tall. Okay, they're tall. Then the S waves are deep in V3. So if you are suspecting HOCM, hypertrophic cardiomyopathy, look for the lead AVL. In the AVL, the R waves will be tall, and in the V3 lead, the S waves will be deep, and that is called as the Comel. I think it is Comel. Yeah, it's Comel criteria. Repolarization changes in the anterolateral leads: 1 AVL, V4, V5, and V6. V4, V5, and V6 have repolarization problems. Repolarization changes in lead 1, V4, V5, and V6, and also in the AVL, but we did not mention that because we were too busy talking about the tall R wave and the deep S wave in the V3. So these are the problems that we find in the hypertrophic cardiomyopathy. Sudden blunt impact, sudden death in the absence of heart damage, that is called as commotio cordis. Yeah, because the heart undergoes sudden electrical discharge. So commotio cordis, it occurs in the athletes with no pre-existing cardiac disease, occurs due to fatal ventricular fibrillation and sudden blunt chest wall trauma. Most commonly occurs in the baseball. Cardiothoracic ratio in children aged less than 1 year. It is the cardiothoracic ratio done with the commotio cordis. Now the next thing is cardiothoracic ratio. So in the children who are less than 1 year of age, it is less than 60%. In children more than 1 year and in adults, it is less than 50%. 0.42 to 0.5, like 42 to 50%. Okay, so in children it is 42 to 50% the cardiothoracic ratio, and in the children less than 1 year of age, it is less than 60%. PDA, patent ductus arteriosus, dependent congenital heart defects. Like the heart defects which depend on the PDA for the existence or for the child to be alive. Coarctation of aorta, hypoplastic left heart syndrome. Okay. Then transposition of greater arteries, total anomalous pulmonary venous return, tricuspid atresia. These 1, 2, 3, 4. These are basically the conditions, not this one, which are associated with a cyanotic. These are basically cyanotic congenital cardiac defects, right? So they need PDA for the child to be alive, and also the hypoplastic left heart syndrome. First two defects require PDA for systemic circulation, the rest require it for the pulmonary circulation. Then after that, we have first two defects require the PDA for the systemic circulation. The first one two are coarctation of aorta and hypoplastic left heart syndrome. Okay, and the rest of the three, which are transposition of great vessels and numbness, pulmonary venous return, and tricuspid arteries, yeah, they needed for what? They need PDA for the pulmonary circulation. PDA, the ductus arteriosus is basically suppose this is the these are the pulmonary arteries, and here we have the aorta which is overlying them. So in children, let's not draw this one. So in children, there is a connection between the aorta and the pulmonary arteries like this, because their lungs are not, they have hypoplastic lungs, not hypoplastic, but their lungs are not functional. So the blood that is entering the pulmonary artery bypasses the lungs and goes into the aorta. In as soon as the child is born, this closure is in the first 48 hours of life. But in the children in which the PDA remains patent, so that is called as patent episarteriosis, and that can have important functionality in these situations. Then effect of PDA closure. If pulmonary blood flow is obstructed in these situations, it can cause cyanosis. If systemic blood flow is obstructed, that can result in hypotension. So yeah. Then the next thing is hypertrophic cardiomyopathy in infants. Uh, Hypertrophic cardiomyopathy, as we have seen in above situation, that there will be peaked R waves in the lead AVL and there will be deep S waves in the lead V3, right? Yeah, and there will be repolarization changes in one AVL, V4, V5, and V6. Okay, so hypertrophic cardiomyopathy, the pathogenesis is maternal hyperglycemia, fetal hyperglycemia, and hyperinsulinemia, increased glycogen and fat deposition in the interventricular septum, dynamic left ventricular outflow tract obstruction. The clinical findings are often asymptomatic, may have respiratory distress or hypotension. Systolic ejection murmur will be present. Imaging on chest X-ray will show cardiomegaly. Echocardiogram will show increased thickness of interventricular septum and decreased left ventricular chamber size. Treatment is intravenous fluids and beta blockers to increase the left ventricular blood volume. Prognosis is spontaneous regression by age 1. So here you can see that hypertrophic cardiomyopathy in infants of diabetic mother, it presents something like this. This is not your regular hypertrophic obstructive cardiomyopathy. This is a fake hypertrophic obstructive cardiomyopathy which goes away in 1 year. The real one stays. Give the beta blocker and IV fluids increase the volume and move on. Like any hypertrophic obstructive cardiomyopathy, increase the volume, less obstruction, so the murmur intensity is decreased. So in front of mother with diabetes mellitus, complications. Maternal hyperglycemia in the first trimester can result in congenital heart disease, neural tube defects, small left colon syndrome, and spontaneous abortion. In second and third trimester, there will be fetal hyperglycemia and hyperinsulinemia. So because of that, there can be increased metabolic demand. Fetal hypoxemia, because the fetal blood supply cannot cope up with that increased metabolic demand. Increased erythropoiesis that will result in polycythemia. Plethora can be a finding. Then there will be organomegaly. After that, there will be neonatal hypoglycemia, macrosomia, shoulder dystocia, brachial plexopathy, clavicle fracture, and perinatal asphyxia, increased glycogen synthesis, glycogen deposition in interventricular septum that will result in hypertrophic cardiomyopathy. What is Kawasaki disease? So Kawasaki disease, age less than 5 and fever for more than 5 days. That's a good one. So classical presentation of Kawasaki disease is fever for 5 days, cervical lymph node more than 1.5 centimeter. There is going to be rash, swelling or erythema of the palms and soles, bilateral non-exudative conjunctivitis, mucositis, coronary artery aneurysm, in IV immunoglobulins within 10 days to decrease the risk of aneurysm, aspirin to decrease the MI and ischemia, also to decrease the inflammation and fever. Fever for more than 5 days in addition to more than 4 of the following mucocutaneous findings that are choral, conjunctivitis, oral mucosal changes, rash, extremity changes, and lymphadenopathy. So Conjunctivitis will be bilateral, non-exudative, and that will spare the limbs. The what? No, 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 not limbs. It is limbus. Limbus is basically suppose this is an eye, and this is the iris. So there is a rim of rim. There is a rim of grayish tissue, which is at the junction of sclera and cornea. That's a limbus or a sleeve of tissue that will be spared in these Kawasaki disease. Oral mucosal changes, erythema, fissured lips, and strawberry tongue. Scarlet fever also has it, but there are certain differentiating factors with which we differentiate the scarlet fever from the this one. Then we have rash, that is blanching and maculopapular rash. Extremity changes like erythema, edema, and desquamation of hands and feet, and there will also be lymphadenopathy. Then we have lymphadenopathy will be cervical, and more than 1.5 centimeter node will be seen in that. Irritability is also a common feature. Labs will show leukocytosis, thrombocytosis, increased ESR, and sterile pyuria. Okay. Treatment: IV immunoglobulins. Start within 10 days of the fever. Onset to prevent coronary artery aneurysm, and aspirin. Assess the cardiac complications by the echocardiography. Risk factor of cardiac complications: prolonged fever more than 10 days, delayed treatment with IV immunoglobulins, and age less than 1 year. So, okay. Disease: adenovirus can cause purulent conjunctivitis, while the Kawasaki disease causes non-purulent conjunctivitis. Scarlet fever causes exudative pharyngitis and a sandpaper textured rash that spares the palms and soles. Kawasaki disease, non-exudative tonsillitis, and blanching maculopapular rash. Scarlet fever has exudative pharyngitis, while the Kawasaki disease has non-exudative tonsillitis. Okay, so just this table must not be together. Like these, this is a separate thing, and it must come below that actually. So, adenovirus causes purulent conjunctivitis, scarlet causes exudative pharyngitis with a sandpaper texture rash that spares the palms and soles, and Kawasaki disease causes non-purulent conjunctivitis and non-exudative tonsillitis, blanching maculopapular rash. Strawberry tongue is present in both Kawasaki disease and scarlet fever. Kawasaki disease epidemiology: 90% of the children are aged less than 5. Increased incidence in Eastern Asian ethnicity. Diagnostic criteria is coral, like fever more than 5 days plus more than 4 of the following. Okay. So conjunctivitis will be bilateral and non-exudative. Then O is for the mucositis, injected fissured lips on the pharynx and strawberry tongue. Cervical lymphadenopathy, more than one lymph node, more than 1.5 centimeter in diameter. I'm sorry, that was L. So R is for the rash, erythematous polymorphous, generalized perennial erythema, and desquamation or biriform rash on the trunk and extremities. And erythema and edema on the hand and feet can also be present. Treatment is with aspirin plus intravenous immunoglobulin. Complication is coronary artery aneurysm. For that we give IV immunoglobulins. And myocardial infarction and ischemia. For that we give aspirin prophylaxis. Then the next thing is viral myocarditis. Etiology: Coxsackie virus B and adenovirus. The clinical feature: divided as pathology in we're talking about viral myocarditis. Okay, so divided as pathology in the left heart, lungs, and right heart. In the left heart, any of these can cause S3 gallop. Volume overload will lead to ventricular gallop, which is S3, and holosystolic murmur, which can be caused in VSD, tricuspid and mitral regurgitation as well. And also in the viral myocarditis, we can find a holosystolic murmur. Lungs can show pulmonary edema, dyspnea, tachypnea, wheezing, crackles due to left heart failure. And the right heart can result in right heart involvement will result in hepatomegaly, and I think that will be pulsatile hepatomegaly or something. Viral prodrome, for example, upper respiratory tract infection often precedes the illness. Diagnosis: initial workup, chest X-ray, cardiomegaly and cardiothoracic ratio of more than 50%. Normally it must be 42 to 50%. And there will be pulmonary edema. ECG will show sinus tachycardia. Echocardiogram will show global hypokinesia with decreased ejection fraction. Normally it must be more than 55%. Normal ejection fraction is like more than 50 to 75%, and if it is less than 55%, so it means that it is hypokinesia. Gold standard in the biopsy. Inflammation and necrosis will be seen. Treatment: supportive by diuretics and inotropes, IV immunoglobulin. Monitor the patients in ICU due to the risk of shock and fatal arrhythmias. Treatment should be started based on the clinical suspicion alone. Complete atriovenous septal defect. Okay, that can be found in the Down syndrome. Is the most common congenital heart defect in the patient with Down syndrome. Other features of Down syndrome patients are epicanthic folds, upslanting palpebral fissures, low set ears and small ears, flat facial profile, short neck with excess skin, furrowed tongue, sandal toe deformity, single transverse palmar crease, hypoplastic in curved fifth finger, and brush field spots. Most common congenital heart defect in the patients with the Down syndrome. Failure of the endocardial cushions to merge result in the VSD, ASD, common arterioventricular valve due to the poor mitral and tricuspid valve development. Common atrioventricular valve. Okay, so the problem is there is just one chamber of the heart, which is like a prominent chamber, like this is the heart. This is the undeveloped atrial septum. This is the less developed vertical septum, and so this is how it works. There's a common atrioventricular valve due to poor mitral and tricuspid valve development. Common atrioventricular valve. Yeah, it pretty much looks something like this. Like everything is communicating. So there is, yeah. So pulmonary vascular resistance falls around the age 6 weeks when the symptoms become evident. Auscultation findings are peculiar to specific heart defects. ASD, if it is present, there will be a fixed splitting of the S2. VSD will show hollow systolic murmur of the VSD, left lower sternal border. AV valve will show a hollow systolic apical murmur, and increased flow across the pulmonary valve will show systolic ejection murmur. Okay, then we have coarctation of aorta. It results from thickening of the tunica media near the junction of ductus arteriosus and the arch of aorta. The clinical features are hypertension in the upper extremities. Lower extremities have the following features: hypotension, hypoxia, decreased oxygen saturation, decreased femoral pulses, and claudication in the adults. Heart failure shows irritability, poor feeding, diaphoresis, cardiogenic shock in the infants, like metabolic acidosis because ischemia, and anaerobic lactic acidosis, decreased urine output because of decreased renal perfusion, prolonged capillary refill time of more than 3 seconds, palpable pulsations of the intercostal vessels in the adults. Auscultation: systolic murmur is heard at the left paravertebral interscapular area, and treatment is surgical repair. Coarctation, congenital heart defect association. Coarctation of aorta is highly associated with the Turner syndrome. There can also be bicuspid aortic valve association with the Turner syndrome. Epstein anomaly is associated with the lithium toxicity. Patent ductus arteriosus is associated with the congenital rubella syndrome. Tetralogy of palate is associated with sporadic, more common, or may be associated with the DeGeorge syndrome. Transposition of great arteries, DeGeorge syndrome, and also the infants of diabetic mothers. Truncus arteriosus is associated with the DeGeorge syndrome. What is TTD? Transposition, DeGeorge syndrome. And then we have cyanosis within 24 hours of birth. HCM epidemiology. It is more common in African American population, and it is autosomal dominant. Cyanosis within 24 hours of birth. Think of transposition of great vessels or truncus arteriosus, especially if there is a single S2. Single S2 is heard in tetralogy, transposition, tricuspid atresia, truncus arteriosus, and hypoplastic left heart syndrome. So basically all the cyanotic heart diseases have a single S2 for some reason. All the above also present with the central cyanosis. Then we have ventricular septal defect of VSD. Small VSDs close spontaneously by the age of 2 years with no long-term sequelae. They present with a harsh murmur. Large VSDs present with soft murmur due to the less turbulence across a large defect. Regardless of size of the VSD, get an echocardiography to determine the location and size of the defect and to rule out other defects. It has a good association with Down syndrome, VSD. So, moderate to large ventricular septal defects, timeline in utero. The pathological changes are that right ventricular and left ventricular pressures are equal. No significant hemodynamic consequence will be seen. Postnatal transition is decreased pulmonary vascular resistance and increased systemic vascular resistance. Left to right shunting through the VSD will be seen. Yes. Infancy, right ventricular volume overload that will result in dilation. Pulmonary overcirculation, left atrium and left ventricular volume overload and dilation. This thing happens when the shunt starts reversing. Yeah. Late childhood, pulmonary arterial vascular thickening, that is increased pulmonary vascular resistance, right to left shunting through the VSD, that is called as Eisenmenger syndrome. Okay. This is basically the characteristic of shifting, I mean, right to left, conversion of a left to right shunt into a right to left shunt. So I don't know why is this happening. Maybe it's a part of the process, something. So then we have the QT prolongation. The QT prolongation can result in torse de pointes, right? Okay, so normal QT interval is in males is less than 440 milliseconds and in the female it is less than 460 milliseconds. Okay. Treatment is refraining from the vigorous exercise, avoiding the medications that prolong the QT interval, maintaining the levels of calcium, potassium, and magnesium. Treatment of choice is beta blockers except the sotalol. And for symptomatic patients or patients with a history of syncope, beta blockers with pacemaker can be given. So, what are the causes of QT prolongation? They can be acquired causes, they can be inherited causes. So, electrolyte derangements like hypocalcemia, hypokalemia, and hypomagnesemia. Medication induced include antibiotics like macrolide and fluoroquinolones, psychotropics like antipsychotics, TCAs, and SSRIs, opioids, for example, methadone and oxycodone, antiemetics like ondansetron and granisetron, antiarrhythmics like quinidine, procainamide, flecainide, amiodarone, and sotalol. The inherited ones are Jervell and Lange-Nielsen syndrome, autosomal recessive, Romano-Ward syndrome, autosomal dominant, Romano is dominant, and dominant Romano. Okay, so Romano-Ward syndrome and Jervell-Lange-Nielsen syndrome, these are inherited causes of QT prolongation, and the other one are acquired causes. The next thing is about the what is that? Tricuspid atresia. In tricuspid atresia, there are minimal R waves. Left axis deviation is seen. Somehow there that is showing like left axis deviation. Tall peaked P waves. Okay, so there are lead sequences as well. In lead 1, we find left axis deviation. In lead V4, there is minimal R waves. In the lead 2, there is tall peaked P waves. In the lead V2, we have minimal R waves. And in the lead V3, there are short R waves. In the lead AVF, there is left axis deviation. It should be suspected in the cyanotic kids with left axis deviation, small or absent R waves in the precordial leads, and tall or peaked P waves. So the three characteristics are tall or peaked P waves, small or absent R waves, and left axis deviation. The clinical features are hypoplastic right ventricle, underdevelopment of the pulmonary valve because of the lack of blood flow to the pulmonary outflow tract. This leads to decreased pulmonary vascular marking on the chest X-ray. We have tricuspid atresia, right? So why isn't there blood flow to the pulmonary outflow tract? Okay, because I don't know. Tricuspid atresia. Yeah, tricuspid atresia. Listen, the problem is that suppose this is the heart and these are the four chambers and the right atrium and right ventricle are connected with the tricuspid valve, and here is the opening of the pulmonary artery and it goes like this, right? If this is atretic, so the blood enters the right atrium, then through some shunt, either the patent arterial arteriosus or maybe AST, it flows to the left atrium, then to the left ventricle and stuff like that. So it never enters the right ventricle. That is why there is underdevelopment of pulmonary valve and artery because of lack of blood flow to the pulmonary outflow tract. That leads to decreased pulmonary vascular marking on the chest X-ray. Associated with the ASD and VSD are necessary for survival. And also, the blood will enter at the VSD, from the VSD it will enter this way. And then it will enter the pulmonary circulation, but not too much. So that is a necessary for the survival. And there is no cardiomegaly. The risk factors for the tricuspid atresia include congenital rubella syndrome, Down syndrome, maternal diabetes, and family history of congenital heart disease. Treatment is surgical repair. Differentials include complete atrioventricular canal defect, increased pulmonary markings. If it is a complete AV canal defect, there will be pulmonary markings, but these pulmonary markings are absent in tricuspid atresia. This one has decreased pulmonary marking on X-ray. The cardiomegaly, no cardiomegaly, in fact, hypoplastic right ventricle will be seen in tricuspid atresia, while incomplete atrioventricular canal defect will find cardiomegaly. Then there is Epstein's anomaly can be differentiated, but in Epstein's anomaly there are tall P waves, right axis deviation in contrast to the left axis deviation seen in the tricuspid atresia and cardiomegaly. Tetralogy of Pallet, decreased pulmonary marking due to the pulmonary outflow obstruction, right axis deviation, and boot-shaped heart in the later stages. TAP VR, it also has right axis deviation. So basically you can see Epstein's anomaly, tetralogy of Pallet, TAP VR, all of them have right axis deviation, while the tricuspid atresia has left axis deviation. Then truncus arteriosus, ECG is normal in neonates, cardiomegaly, and increased pulmonary vascular markings also present in truncus arteriosus. Then we have congenital heart disease routine screening. How do we do that? It is done by the preductal and postductal pulse oximetry. Echocardiogram is indicated for a positive screen, which is less than 90% in either extremity. For a positive screen. So what is a positive screen? If on pulse oximetry we have less than 90% oxygenation in either extremity, less than 95% in both upper and lower extremities, and more than 3% difference between upper and lower extremities, that is a positive screen, and on pulse oximetry, and for them we do the echocardiography. Remember, acrocyanosis, blue extremities and pink body, is a benign finding in the first day of life due to initial vasoconstriction. Indication for screening test is chest X-ray. If the patient has tachypnea more than 60 per minute or increased work of breathing, for example, retractions. Echocardiogram, if positive pulse oximetry test or central cyanosis. Electrocardiogram, ECG, if the patient has bradycardia or suspected to have neonatal heart block. Hyperoxia test, administering 100% oxygen when it is required to distinguish the cause of central cyanosis. Pulmonary cause improve with oxygen. Cardiac cause does not improve with oxygen. Then we have routine newborn care. So there are some preventive care mechanisms, then we have screening care mechanisms. So let us look at them. So the preventive care includes intramuscular vitamin K. Erythromycin IU ointment only prevents the gonococcal conjunctivitis and hepatitis B vaccines. Screening. Newborn screening include metabolic and genetic disorders, hyperbilirubinemia. Hearing screen, pre and post ductal pulse oximetry, congenital heart disease, hypoglycemia in selected populations. Silver nitrate, which is not used now, but look for a question which asks for eye problem in less than 24 hours because of silver nitrate. Gonococcal 3 to 7 days conjunctivitis, and chlamydia causes 5 to 14 days of conjunctivitis. And actually, gonococcal causes early onset conjunctivitis within 3 to 5 days, while chlamydia causes a late onset conjunctivitis within 5 to 14 days. Then we have the next thing that is called the APGAR scoring. So the APGAR score include APGAR, appearance, color, pulse, grimace and reaction, activity and muscle tone, and respiratory effort. So 0 points for Appearance and color is completely blue or pale. 1 point means blue, body pink, and extremities are blue, which is acrocyanosis due to vasoconstriction and normal in first days of life. And the point number 2 is completely pink. Pulse is 0 is absent, 1 means less than 100, and 2 means more than 100 per minute. Grimace means 0 point is if it is absent, 1 point means grimace grimace is there and all the child whimpers, and 2 points mean cry, sneeze, or cough. Activity, muscle tone, 0 point means the child is limp, 1 point means there is some flexion, and 2 point mean active or spontaneous movement is there. Respiratory effort, point 0 means it is absent, point 1 means slow, weak cry, and point 2 means it is regular and good cry. Post pericardiotomy syndrome. It is a pleuropericardial disease that occurs days or months after the cardiac surgery or injury. Inflammation from surgical intervention can lead to pericarditis, pericardial effusion, and cardiac tamponade. Progression to tamponade is characterized by the Beck's triad, distant heart sounds, distended jugular veins or scalp veins in the infant, and hypotension. So these are the Beck's triad, like distant heart sounds, uh, you know, distended jugular veins or scalp veins for the infants because we can't see the jugular veins for some reason, and hypotension. It can also, these three things can be present. Chest X-ray shows cardiomegaly. Treatment is pericardiocentesis and pericardiectomy. So post-cardiotomy syndrome and pericardial effusion in week number 1, you can see that there is costopenic angles are like this 1 week ago, and now they are like all the way here. Stomach bubble is over here, and enlarged cardiac sellout. So this is a characteristic X-ray of the post-pericardiotomy syndrome or pericardial effusion. Then we have vascular rings. So this is normal anatomy in which this thing is the esophagus. Then in front of the esophagus we have trachea. This is from the posterior anterior view, and then the aorta is present like this. So the vascular ring is formed such that the ring of aorta is formed around the esophagus and trachea and is surrounding them, forming a vascular ring, and this is the double aortic arch. It results from the abnormal development of aortic arch causing the tracheal, bronchial, or esophageal compression. It has two types: complete, for example, circumferential around the trachea and esophagus; incomplete, for example, pulmonary artery, sling. Up to 50% of the patients have a cardiac anomaly. Presentation: age less than 1 year. Respiratory symptoms like biphasic stridor, which gets better with neck extension, wheezing, coughing. Esophageal symptoms include solid food dysphagia and vomiting. Diagnosis is barium swallow to find out indentations and MRI with angiography to confirm. Okay. Differentials: asthma, no stridor. Stridor is a symptom of upper airway obstruction. Croup, present with fever, rhinorrhea, and acute inspiratory stridor, responds to nebulized racemic epinephrine. Laryngomalacia, it will have inspiratory stridor. It gets better with a prone position and lying on belly. Laryngomalacia gets better with prone positioning of the baby because the gravity will assist in opening that collapsed trachea. Epiglottis, life-threatening inspiratory stridor and drooling. Okay. Then epiglottitis. This is life-threatening and inspiratory stridor, and with drooling will be seen, and this is characteristic with the Haemophilus influenza. Right? Larynx falls and obstructs so bad with supine, so we have to make the child in prone position in the case of laryngomalacia. Foreign body aspiration, acute onset, history of choking or gagging. Differential diagnosis of the stridor. In acute settings, it can be because of croup, like 6 months to 3 years old children can have croup, most common in infants and toddlers. Barky cough, inspiratory stridor, fever, rhinorrhea, and congestion will be there. Foreign body aspiration, most common in infants and toddlers. Acute onset of inspiratory stridor and or wheeze without infectious symptoms. Chronic one, laryngomalacia and vascular ring. So laryngomalacia can have inspiratory stridor, which is most prominent in the infants, and stridor worse when supine, improves when the child is prone. It presents in infants less than 1 year of age. Biphasic stridor that improves with the neck extension. Then the next thing is about the ventricular septal defect. The VSD can have a murmur which is holosystolic at the left lower sternal border, diastolic rumble at the apex due to increased flow of blood across the mitral valve. The increased blood is because of the left to right shunting. Prominent S2 because of increased pressure to flow to the pulmonary valve. Then there will be a prominent S2 because of increased pressure to close the pulmonary valve because there is ventricular septal defect and increased pressure is required since there is ventricular septal defect in suppose at the heart and this is the ventricular septal defect. More and more blood is flowing across this defect and more blood is definitely entering the pulmonary circulation, so more pressure is required to close this valve because the inflow pressure is too much, so resultantly the S2 will become more prominent. VSDs may be small or moderate. Either small moderate they produce 2 to 6 by 6 hollow systolic murmur, like 2 by 6 or 6 by 6 hollow systolic murmur because of the turbulence. The small VSDs, which are less problematic, which can close spontaneously, they produce the highest turbulence and a very high pitched murmur. They resolve spontaneously in most cases by the age of 2 years. Large VSDs produce 1 by 6 or quieter murmurs, and treatment is a combination of medications like diuretics and surgical closure. Etiology of palate. This murmur is because of the pulmonary artery stenosis. We will find a harsh systolic murmur which is heard over the left upper sternal border. Single S2 comprise, okay, so S2 will be a single sound. Normally S2 has two components, the aortic and pulmonary component, but in all the central cyanotic conditions, the S2 is a single sound. So single S2 comprise the normal aortic and the inaudible pulmonary component. Presentation depends on the right ventricular outflow tract obstruction, increases with exertion, feeding, crying, and agitation. Treatment, acute management is knee chest positioning. Like if the child is becoming cyanotic, take him to the knee chest position. Inhaled oxygen, stimulate respiratory vasodilation, pulmonary vasodilation, and decrease the pulmonary resistance. IV fluids improve the right ventricular filling and pulmonary flow. Shifting the right to left shunt to left to right, so more blood flows to the pulmonary circulation. Then increase blood flow from the VSD, shifting the right to left shunt to left to right, so that more blood flow flows to the pulmonary circulation. Okay. Then increase the blood flow from the VSD, more blood to the pulmonary circulation, that cyanosis gets better. VSD, moderate or large ventricular septal defect. Timeline. In utero, we have talked about this one before, but let's see it again. So right ventricle, left ventricle pressures are equal in utero. No significant hemodynamic consequences. Postnatal transition is that there will be a decreased pulmonary vascular resistance and increased systemic vascular resistance that normally occurs. So that will result in a left to right shunting through the VSD. In infancy, right ventricular volume overload and dilation will be seen. During pulmonary overcirculation and left atrium to left ventricular volume overload or dilation will be seen. In late childhood, pulmonary arterial vascular thickening increase the pulmonary vascular resistance. Right to left shunting through the VSD, that is Eisenmenger syndrome. Next topic is about the rheumatic heart disease. Suspect the rheumatic heart disease if the patient has a history of polyarthritis after a febrile illness and presents and the presence of mitral regurgitation on echocardiogram. Prophylaxis of penicillin G every 4 weeks is needed to prevent the recurrence. Then the next thing is prophylaxis with the penicillin G every 4 weeks is needed to prevent the recurrence. The patients should be monitored every 6 to 12 months for the signs of left ventricular dysfunction. Antibiotic prophylaxis for secondary prevention of the rheumatic fever. Firstly, severity, uncomplicated rheumatic fever, duration of therapy following the last attack, 5 years or until age 21 if it is uncomplicated rheumatic fever. If it is with carditis but no valvular disease, we have to give the treatment for 10 years or until age 21. With carditis and valvular disease, 10 years or until age of 40 years. Whichever duration is longer, intramuscular penicillin G penicillin every 3 to 4 weeks is preferred. Then the next thing is effect of maneuvers on hypertrophic cardiomyopathy. Effect of maneuver on the hypertrophic cardiomyopathy and mitral valve prolapse. Valsalva, abrupt standing, and nitroglycerin administration. All of these things decrease the preload. They will decrease the left ventricular volume, and thus the murmur intensity in hypertrophic cardiomyopathy and mitral valve prolapse will increase. Sustained hand grip, squatting, and passive leg raise. The sustained hand grip and squatting increase the afterload. Squatting and passive leg raise also creates a preload. So in these conditions, the left ventricular volume is increased, and thus the murmur intensity will decrease, as you can see here. So this is not true for any other kind of murmur. For the HCM and mitral valve prolapse, the Valsalva abrupt standing and nitroglycerin will increase the murmur intensity, whilst sustained hand grip, squatting, and passive leg raise will decrease its intensity. Then we have this thing that physical examination of hypertrophic cardiomyopathy, anterior displacement of the mitral valve leaflet, dual upstroke carotid pulse due to the mid-systolic obstruction during the cardiac coarctation, systolic ejection murmur along the left sternal border with a strong apical impulse. Cyanotic heart diseases. So the cyanotic heart diseases are transposition of great vessel, tetralogy of palate, tricuspid atresia, truncus arteriosus, total anomalous pulmonary venous return with obstruction, that is TAP VR. So transposition of great vessel, on examination you can see that in most of them, like in 3 of them, we have a single S2 with or without ventricular septal defect murmur, because in transposition of great arteries we need a VSD or PDA maybe, so they can have a VSD murmur. X-ray findings have egg on a string heart, narrow mediastinum. Tetralogy of palate, it has a hard pulmonic stenosis murmur and a VSD murmur. Boot-shaped heart, right ventricular hypertrophy. Tricuspid atresia, there is a single S2 and VSD murmur. There will be minimal pulmonary blood flow. Truncus arteriosus, single S2 and systolic ejection murmur, increased flow through the truncal valve. Increased pulmonary flow and edema will be there. Total anomalous pulmonary venous return with obstruction. Sphere cyanosis and respiratory distress will be there. Pulmonary edema with a snowman sign, and large supraclavicular vein and superior vena cava. So because of total anomalous pulmonary venous return, we have a snowman sign. It is something like a snowman, maybe. This is a snowman, and this is depicted here. Because of enlarged supracardiac veins and superior vena cava. And this is agonistic appearance that is seen in the tetralogy of palate. So this is auscultation of the heart murmurs, and there are certain maneuvers. So the Valsalva maneuver, what it does, early strain phase decreases the venous return. All the murmurs except hypertrophic cardiomyopathy and mitral valve prolapse will be decreased, because when the venous return is decreased, the blood flow into the heart is decreased. So logically, all the murmurs will be decreased, but with an exception of hypertrophic cardiomyopathy and mitral valve prolapse. Late release increase the venous return, increase the right-sided murmurs. So hypertrophic murmurs that get louder with Valsalva are hypertrophic cardiomyopathy, decreased left ventricular volume, increased gradient, and mitral valve prolapse, decreased left ventricular volume and increased leaflet prolapse. Murmurs that get softer, all other murmurs, decreased flow through the stenotic or regurgitant valve during the strain phase. Standing, that decreases the venous return, similar to the strain phase of Valsalva. Again, the result is similar. Hypertrophic cardiomyopathy and mitral valve prolapse will be decreased because of the very same mechanism, that they have decreased left ventricular volume and increased gradient, or maybe decreased left ventricular volume and increased leaflet prolapse. And all other murmurs will become quieter because of decreased flows through the stenotic or regurgitant valve during the strain phase. Squatting, it increases the venous return, increases afterload by kinking of the femoral arteries, and increase the reverse flow. So the murmurs that get louder are aortic regurgitation, mitral regurgitation, and ventral septal defect. Basically, all the murmurs with regurgitant phenomena, they become increased with the squatting because that increases the venous return. The murmurs that get quieter are hypertrophic cardiomyopathy and mitral valve prolapse. Because hypertrophic cardiomyopathy, because of increased payload, decreased gradient across the outflow tract, and decreased obstruction. Why does mitral valve prolapse get quieter? Because of increased left ventricular size and decreased leaflet prolapse. Hand grip increases the afterload, increases the blood pressure, and reverses the flow across the valve. So the aortic regurgitation, mitral regurgitation, and VSD will become quieter, while hypertrophic cardiomyopathy and aortic stenosis will become loud. This because of increased left ventricular volume. Okay, I think I just no. The louder murmurs are these. These become loud and these become quieter. Like so, the aortic regurgitation, mitral regurgitation, and VSD become loud, while the hypertrophic cardiomyopathy and aortic stenosis, they become soft. Decreased transvalvular pressure gradient and stuff like that. Dijot syndrome, the mnemonic is catch 22. So this is catch 22. Okay, so the pathogenesis is chromosome 22 Q11.2 deletion, defective development of the pharyngeal pouches. So the clinical features are conotruncal cardiac defects like tetralogy of Fallot, truncus arteriosus, and interrupted aortic arch, abnormal facies, thymic hypoplasia or aplasia with a T cell deficiency, craniofemoral deformity, craniofacial deformities like cleft palate, and hypocalcemia and hypoparathyroidism. So this was all about CVS, and then we'll continue with the dermatology in the next unit. Until then, Allah Hafiz, fi amanillah, and take care.